So the topic given to me is little atypical and how we deal with it. Tips and tricks, I think with a small number of cases I have, I'll try to share my experience with the expert can chip in and help me out. So atypical shunts are lesions which are anomalous, uncommon cardiovascular communications resulting in intercircular mixing. When we are telling atypical, the typical one divided ASD, VHD, PDA, that seems to be typical. It's arbitrary classification. It can be cardiac or extracardiac. The cardiac one, coronary cameral fistula, the commoner one, aorta atrial tunnel, RSOV, pulmonary artery to left atrial connection, maybe left or right. And in the extracardiac category, the most common is pulmonary arteriovenous fistula or pulmonary AVM category. Aortopulmonary collateral we see very commonly in the cyanotic heart disease, Abernethy malformation and vein of Galen. This is not comprehensive, but some illustrative example. So most important thing in this category of atypical shunt is suspicion of that shunt. The patient will present with either left to right or right to left shunt. The symptoms and clinical feature of the shunt lesion, if present, along with unexplained cardiomegaly, heart failure, unexplained lung shadow in the X-ray, especially with the cyanosis, the presence of unexplained chamber enlargement, like all chambers are getting enlarged, so the possibility of RSOB to RA is prominent. Or unexplained pulmonary hypertension in an with a left to right shunt suspicion, especially vein of Galen malformation, the unexplained pH, but we are getting left to right shunt, so we need to do a little bit more introspection in the patient's imaging. And we are not getting an typical shunt. So suspicion plus absence of typical shunt, we move towards getting an atypical one. This is one of that example where a young adult, 27 years old, presented with a cyanosis, no significant intracardiac abnormality in terms of auscultatory finding, but there was an X-ray shadow in the right parahilar region which was abnormal, and these things were not matching. So I'll come back with another example, a baby who presented with features of heart failure or significant distress, but referred with a diagnosis of PFO. So this cardiomegaly with little bit of increased vasculature was not matching. So abnormal X-ray not matching with clinical diagnosis or clinical finding. So the imaging is most important, and the echocardiographer, who should be in clinically directed detailed screening of the heart and allied structure. The specific area of imaging, for example, checking the cranial imaging in a small child for possible vein of Galen, or a hepatic imaging to look for Abernethy malformation or abnormal aortopulmonary collateral. So this baby is very interesting one, came to me in the first week of life with some breathing difficulty. The referral diagnosis was a PFO. So in the initial scanning, there was looking like multiple jet of PFO, but the gradient was very high. And actually, on interrogation, the diagnosis was aorta to right atrial tunnel. The suspicion and then getting a further detail in and backdrop of the clinical finding helped. So in the imaging component, in the adult population, transesophageal echo, we all know, is definitely helpful to delineate. This is another example of aorta to right atrial tunnel. We can see the very, very dilated course of the tunnel, aneurysm formation, and then it is draining to the right atrium. The next important in the imaging is the contrast echo. We are getting cyanosis, abnormal cardiac shadow. So when we are doing contrast echo, we can confirm by appearance of the contrast material in the left heart chambers within few beats, and in the parasternal short axis view, by looking at which vein it is coming, it definitely helps. So this is an example of left pulmonary artery to LA fistula, and we can see the contrast coming back from the left pulmonary vein. Similarly, another example where the contrast was was coming from the right pulmonary vein, and it was a right pulmonary artery to LA fistula. It is the same patient where there was an abnormal intracut shadow in the right side. So if we compare for the need of second imaging, conventional cardiogram versus the CT angiogram versus regular angiogram, CT has an advantage. It is less invasive, OPD based. We can see the lesion very well. 3D MPR mode will help us to delineate the anatomy, plan the intervention, and 3D reconstruction also give an insight. But the problem is radiation a little bit more. Conventional angiogram, if we are very sure about our procedure, how we are going to do it, in the echo we can directly take in the cath lab. The lesion we can see in multiple views. We can do balloon occlusion to understand the hemodynamic impact of that procedure. And in selected cases, we can do rotational angiogram, but it is invasive. So once we have taken in cath lab, means we have committed to do something. So as we discussed, 3D CT and multi-plane assessment for the anatomical delineation and deciding the procedure immensely helpful. So this is an example of that left pulmonary artery to left atrial fistula. You can see how big was the aneurysmal pathway, and the narrowest point was 24 millimeters. So the CT was very, very helpful in planning the procedure. So this is another, the same patient, RPA to LA fistula, and again in the lateral view, it showed the narrow point, and we planned our procedure based on that. This is an extremely rare, possibly first in world type case done in by Dr. Shiva in Chennai. The RPA to RA fistula, it's extremely rare. It looked like it's a PDA type initially. And you can appreciate that, and CD helped us again. This is the reconstruction, both branch PA, and this is that abnormal channel. In angiogram, we have advantage. Based on our CT data, we can decide, we can delineate the fistula or the abnormal tract in multiple views. This is that example of child having aorta to RA tunnel, which came with a referral diagnosis, PFO. We see, we delineate that arteries, where from it's originating, and we are planning where to hook our device. This is an add-on thing. In atypical shunt, we don't know what exactly is the position of that communication. So rotational angiogram definitely helps to know where exactly it is. In the best plane, we can freeze and try to cross-check. So you can see the best position, which help us to cross the fistula very well. So balloon occlusion, the same patient of the Fontan tells us what's the size of the device, it helps. And by closer, any hemodynamic implication in that particular case, Fontan pressure, there was not much of elevation. And we occluded this particular case by 8-3 Tyshak balloon. This is another example, still image from aorta to left pulmonary vein fistula. After balloon occlusion, the pulmonary artery injection showed there was no flow. So in the left lower region, so left lower region was predominantly supplied by the fistula. So when we are planning, we should plan with hardware preparation. Maximum things should be available based on the particular case, multiple size short sheet, braided sheet, regular sheets, different types of diagnostic and guiding catheters, exchange length and straight tip, thermo wires, stiff wires, super stiff wires for difficult anatomy, snares for loop creation as well as for bailout, and definitely multiple types of occluders. So this is wire loop from two places, two example, one from the RSBC, one from that IVC. The next one was from the aorta to RA tunnel. So much tortuous was the course. Stabilizing the wire loop is very easy, but without wire loop also we can stabilize the wire for advancement of the sheath. In this particular case, it's in case of aorta pulmonary window, and the wire is fixed and stabilized in the right axillary artery. axillary artery, and we can see the wire is nicely going there, that the sheath is going smoothly by fixation of that wire in the axillary artery. This was one of the most difficult negotiation of the sheath, where there is no wire loop. So we are seeing very, very tortuous course, a braided sheath in a LPA to LA fistula. Check angio helps us to understand where exactly we are. So we repositioned our device in aortopulmonary window, and the next one was in the aorta RA tunnel. So changing strategy, this is an RPA to LA fistula. We closed with a transcatheter, transseptal puncture route for better delineation of that anatomy. Intra-procedural echo helps us to understand where is, if there is any residual. In this particular case, AP window, there was significant residual flow in the MFO. We changed to regular duct occluder, which was of bigger size. We should plan anticoagulation, particularly in these cases of abnormal fistulas, INR of 1.5 to 2 for at least 1 year to prevent thromboembolic complications. So I have already shown multiple examples. So this is one example where RSOB to the RA was closed from non-coronary sinus. Second was a large one from RSOB to RV, closed with a large duct occluder.
You just need to summarize your slides.
Yes, it's done. So atypical shunt lesions require detailed evaluation of anatomy and hemodynamic effects. Patient's family members should be well counseled for nature of the cardiac affection and plan of intervention. Planning of closure based on multimodality imaging. Appropriate hardware should be available on shelf based on the lesion, and a team approach. We require help from all modalities. Thank you.
Thank you, Anil.